Thank you. And this meeting is being recorded because it is a public meeting. And after the meeting concludes, the recording will be posted on our committee's webpage. For everybody's reference, today's agenda can be found under the first tab in our materials. And as another reminder, if you are not a member of the committee, please remember to turn your camera off. Dr. Judy Zerzenthal, our chair of the Advisory Committee on Primary Care, will now call the meeting to order.
Thank you, Jean Marie, and hello, everybody, and welcome. It is 12. I wish it was 12:02. It is 2:02 p.m. and I call the March 30th meeting of the Advisory Committee on Primary Care to order. And I'd like to give everyone a warm welcome. This is our 6th meeting, so that is very exciting. So I'll start with an overview of the agenda. So we're going to approve the February meeting summary, have time for public comment, and then we're going to have a presentation about our progress to date. The Center for Evidence-Based Policy is joining. They're going to help us with the meeting running and with the organization of this committee. So, so this is their first stop at that. And then we are going to go back to the code level discussion of primary care services. We're changing up how we're doing it a bit, and so I am hopeful that that will result in us being a little speedier and helping with the discussions that we need to have. So next, we'll start with the roll call. And I guess I do that. So Crystal. Sharon Brown. Tony, I know I saw you.
Yeah, Tony Butrell, family physician in Leavenworth, past president of the Washington Academy of Family Physicians and past chair of a primary care investment task force.
Great. Michelle, I think, is not joining. Nancy?
Here.
Tracy? David?
I'm here, thank you.
DC?
Present, thank you.
Sharon Eloranta?
I am here.
Excellent. Greg?
I am here for the first hour only today.
Okay, thanks. Chandra?
I'm also here for the first hour.
Meg? Cheryl? Lon?
Hello, I'm here.
Great. Kevin? Eileen? Katina?
I'm here.
Excellent. Mandy?
I'm here.
Jonathan? Sarah? Linda?
Hi, good afternoon.
Sean?
Present.
Stacy?
Good afternoon, I'm here.
Ginny?
Good afternoon.
And Maddie?
I am here. Good afternoon.
Excellent. And are there any committee members that are on that missed their name?
Tracy's on.
Oh, great.
I think I saw Crystal too, Judy.
Okay. So now I'd like to move, I'd like to have someone make a motion to approve the meeting summary of the February committee meeting.
This is
I
Katina.
will so move. I will second. Maddie Wiley.
Great. All in favor?
Aye.
Aye.
And those opposed? Great. Meetings have passed, or minutes have passed. I have a cold today. I'm a little struggling. So next is public comment, and then after public comment, our colleagues from the center will talk about our committee progress. Oh, and I didn't do this right. So here is the calling of order of people. I was just doing my task like I was supposed to. So yes. So now it is time for public comment. And when you're called on, please state your name and affiliation, if any, before speaking. Raise your hand just once so everyone has a chance to speak, and you're also welcome to provide comments in writing by email at any time. This is the time for public comment. Any Q&A sessions during the meeting are time for commission members to ask questions. And so let's see if there is public comment. Oh, and excellent. Katarina?
Hi, yes, thank you. I'm Katarina Lamarche from the Washington State Hospital Association. Wanted to thank you for the opportunity to provide comment and engage in this really important work. Members on the Healthcare Provider and Carrier Advisory Committee weren't able to give feedback on the definition of primary care because their meeting was canceled. So we would like to suggest including the why of primary care in the definition being considered by this committee and the board. We believe the goal is to maintain a state of overall health and wellness for each individual, and this should be recognized in the definition. We would also note that most healthcare systems in the state provide primary care services in addition to hospital services, and that access to primary care is often the best way to prevent more expensive emergency room visits and hospitalizations. Ensuring our primary care and outpatient services are adequately supported is critical to maintaining an efficient and cost-effective system. And we also wanted to comment that we think it really is imperative that the work of the committees and the board is structured so that the board can have sort of the full benefit of the expertise on the committees before it makes decisions. And one last thing, we also think it's important to maintain sort of the spirit of inquiry and seeking to understand the marketplace dynamics and cost growth, both an inpatient and outpatient basis before advancing system fixes. Thank you for considering our comments.
Great, thank you. Do any committee members have any questions? And any other public comments? Okay, thank you. And now I will turn it over to Shane Mofford and Amy Clary from the Center for Evidence-Based Policy to review the goals of today's discussion and our committee's progress to date.
Great. Thanks so much, Dr. Zerzenthal. And I'll kick things off and then hand it to my colleague Shane after that. So hi, everyone. I'm Amy Clary, a senior policy analyst with the Center for Evidence-Based Policy, and I'm part of the team that's supporting the Healthcare Authority in this work. So today, if we jump to the next slide, we'll review our progress to date and today's goals, and then we'll segue into a code level discussion of primary care services. So next slide. We will today recap some decisions that have been made by this group regarding the providers who deliver primary care and the settings where it is provided. And then, like I said, from there, dive into a discussion of the services. So on the next slide, as far as progress to date, and next slide again, thanks to the work of this group, the hard work of this group, the who and the where of primary care have been largely finalized, as well as a general definition of primary care. And last month, this group discussed claims-based primary care services at a high level, and then started to get into that code level conversation that will be continued today. And so to continue our recap on the next slide, this is the definition of primary care established by this group, and it's a great foundation to keep in mind as we proceed into our work today. Next slide, please. So during the February meeting, it seems like a long time ago now, you discussed and voted on the categorization of advanced practice registered nurses, as well as physician assistants, and also on the list of facilities that are considered primary care facilities. And like I said, we started on that services conversation. So on the next slide, this is a slide you've seen before, and it's just a good review of the parameters that guided your work in determining the providers, the facilities, and the services that comprise primary care. And so just a reminder that part of the guiding principle is not changing. Statutory categories already in place. We also note here on this slide that future data analysis may inform refinements. And so just keeping that in mind as we proceed through our work today. And then moving ahead to briefly revisit your work on facilities, here is the list on the next slide. Here is your list, great, that this group created of primary care facilities. And so again, with the note that this approach may be informed by data analysis that may occur in the future to shed more light on this. I should also note that the meeting summary that you just approved in today's materials has a really thorough recap of the robust discussion in the last meeting about facilities. So this is where we landed last time on facilities. And then moving ahead to providers, these slides capture where the group landed on the list of primary care providers. So you can see that on the narrow list that advanced practice registered nurses, internal medicine, pediatrics, and physician assistant were added to that narrow list. And so this is what the narrow list of primary care providers looks like after last meeting's conversation. And then on the next slide, this recaps the broad definition of primary care providers, and it shows the decisions that this group made related to adding advanced practice registered nurse psychiatric mental health, and then also physician assistant psychiatric mental health, and removing homeopath. And so taken as a whole, these slides, primary care providers, broad and narrow, and facilities list and definition of primary care, it's really a substantial body of work that this group has accomplished over your meetings. And so I think as we move ahead into our conversation today of the what of primary care, the list of services, it's a really great opportunity to appreciate the solid foundation to build on that this group's work has accomplished. And so now, if we jump ahead to the next slide, I'll now hand it over to Dr. Zerzan-Thule to lead us through the decision on whether the group approves the facilities list and the narrow and broad provider list.
Great, thank you, Amy. So as a reminder, we do want to do a sort of run of the data before we call this all the way finished, and we will share that data with you once we're there to see if there are any final tweaks we want to do. But right now, I want to see if there's a motion to approve this updated facilities list and narrow and broad providers list as final, pending future data analysis. Would anyone like to make that motion?
This is Maddie Wiley. Linda Van Hoff just raised a question. We have advanced registered nurse practitioners listed as APRNs because nationally that's the way we're going. But in the state of Washington, we are still legally ARNPs. I don't know if that makes a difference for this list or not.
We could make a slash and include both the terms.
That would certainly cover it, because at some point Washington State may very well end up going that same way to APRN. So yeah, that would be my recommendation then.
Okay, great. David?
Yeah, sorry, I missed the February meeting, so you may have already covered this. I'm just thinking about the intersection between these provider groups and specialties. You know, for example, if there's a PA in an orthopedic surgery practice as opposed to primary care practice, have you already addressed that issue?
We have not. And there are some, there's some coding that includes sort of general practice. I can't remember, I didn't pull that up. But there's some coding that does suggest surgical versus medical practice. And so for PAs, we were going to use the medical practice coding rather than the surgical. There's a little bit more nuance into the APRN categories that helps tighten that up a bit, but there's less for PAs for sure.
Okay, yeah, I'm just thinking at some point, somebody's gonna have to code in the claims data to identify primary care, and that's more complex than these concepts that we're talking about at this level.
Yes, that is true. And I know, for example, the Alliance has a good provider list that then you sort of check the box of every person. I think that may be something we want to discuss, is sort of, do we tag specific people as primary care and update that every year? That takes a fair bit of work for sure, but then it's a little more specific.
Thanks.
Nancy?
Yeah, so, and I apologize, I missed the February meeting as well. So I had a couple of questions, one of which may not have an answer, but the first question on all the facilities, how do we handle a home care visit? I recognize that a home is not typically a facility, but a lot of primary care can happen in the home, and I would think that it would be ideally happening in the home in certain circumstances. And so I'm just wondering where that fits on the facilities list. And then my other, I guess, comment is more about, we have this narrow list of providers and the long list. And one of the things, because our definition is effectively a team, so all of these people have to be within a team to be considered primary care, because that's part of our definition. So that, I guess that's more of a comment, but I'm curious what people's thoughts are on that.
Yeah, we haven't thought about the team part. I know when we get to codes, there are codes for home visits, and like telehealth we included as a modifier. Usually there's still a facility that is billing all of those. It's that is about as far as I know into the coding, but I do think even though a visit might happen in the home, it still gets billed as from an office at some point. So we could look into that and bring it back to the next meeting, because I don't want to get too far off base from this, unless
there is an
anyone else.
ICD-9 code for home visits, and I've used it. And when I've
Right,
been
and that's what we're going into now. So this is the facility part and the provider part, and then we have a whole list of codes that Shane's gonna go through. Yeah. Tracy?
Hi, I apologize, I missed February as well. Did the group discuss pharmacists? We have embedded them in our primary care offices and they're seeing patients.
We did not discuss pharmacists.
Okay. Is there opportunity to do that, or are we closing the list?
There could be. I think we started with sort of copying where other states have been, so I don't know that other states have included pharmacists. Yeah, so I think we could. I think one piece, and this is getting into the next part of our presentation, I think one thing we want to define the bulk of primary care, but we don't necessarily want to identify every single service, because what we identify as primary care spend will be both the place that we know money is going to primary care for certain, and there's wiggle room around that, and if there's a place for future investment, this will guide that. And so I think we could talk about pharmacists. I think we need to I think we need to sort of be careful about that. And Jean Marie, I'm wondering if we should take this decision offline for now and move on to the rest of the meeting so that we can bring back some of these things at the next meeting.
If you'd like to, we can. That's yeah, we can do that.
And I don't mean to derail, I'm just wondering, I mean, we're truly experimenting at this point, you know, with hypertension, insulin management, and pain medication. And I think just wanting to leave the door open to experiment and not preclude payment. So I don't know if this definition could potentially, you know, limit our use in the future. And if not, then I think it's fine that we not be incredibly inclusive, but just wanting to leave the door open for utilizing all types of licensed providers, you know, within their scope.
Yeah, and for sure, pharmacists are an important part of that, and I think they can provide a nice benefit when they're embedded in a practice. Yeah.
Judy, the only thing I would add is that with these additions that have come up, given that they weren't widespread across other states, I wonder if this whole pending future data analysis allows some wiggle room for us to approve, like just conditionally approve today, and as we do data digging to add in. If you don't feel comfortable with that, though, we can certainly postpone.
Oh, that's a good idea. We could take a look at how much pharmacists are included in this, and if
Exactly.
it's a lot, yeah, or sort of
it would be, because, you know, we're sort of trying it, using them in an unconventional way. Usually it's people doing like polypharmacy consulting or something. We're using them as seeing patients, but that sounds good if we can revisit later.
Okay.
I move to approve the facilities list and provider lists.
Great. Is there a second?
I second.
Okie doke. All in favor, say aye.
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 Any opposed? Okay, the motion is approved. So now I'm gonna toss it over to Shane, I think, plus minus Amy, for starting to talk about the code list again.
Great, thanks very much. Hello, everyone. My name is Shane Wofford, also with the Center for Evidence-Based Policy, and I am going to do a little bit of level setting before we dive into looking at the specific codes. Keep in mind, we have a fairly massive code list to get through, and the purpose of this level setting is to help you really focus on kind of a narrower way of thinking about primary care so that we can get through the code list with our sanity intact, essentially. So if you could go to the next slide, please. This is just a reminder that there has been work done on primary care definitions. You can see some of the broad strokes of what was done with the OFM primary care definition using the broader of the two that they developed, and also the BRIE primary care services that were previously looked at. Kind of the key differences between the two being that care coordination and urgent care were included in the BRIE definition. And then you can see the general categories that were included as primary care definitions. For the task today, we have tried to bucket the codes into discrete categories. Hopefully those categories resonate with your thinking on, is this truly a primary care service or not? But we'll see how that goes. But I think this is a helpful framing to keep in the back of your mind as we think about, is this truly a primary care service? If you could go to the next slide, please. Another thing to keep in mind too, that even if something is not defined as primary care, that doesn't mean that the service wouldn't be paid for in the future for primary care. We really are just trying to build a concrete definition of primary care as required by Senate Bill 5589. But many of you, actually, I know from participating in the primary care transformation model development process, and this is just a reminder of how these two processes overlap as well. So with the primary care transformation model, in a nutshell, it's creating a standard framework by which primary care services at a conceptual and value proposition level are identified, really with the goal of providing the right supports for primary care to thrive and promoting and incentivizing integrated whole person care. And then the scope is different, but overlapping with the work that you're doing. So really focused on creating a statewide definition of primary care, recommending measurement methods for claims and non-claims-based spending, recommending ways to access and use primary care, and recommending ways to achieve and sustain primary care expenditure targets. Both of these things do ultimately have an aspect around increasing primary care expenditures while decreasing total healthcare spending, but they are different concepts, and we're really, again, focused on the definitional aspects today. So if you could go to the next slide, please. So as we walked through already, and Amy gave a great overview, you've talked about the who and the where. It sounds like there's still a few outstanding questions around that because this is complicated. But what you can see is that we're about to dive in on the what aspect. And the what is specifically for the set of providers and the set of locations where they're rendering services, which services should be included in that set of codes that contribute towards the 12% target that's outlined in the statute. If you could go to the next slide, please. So just to try and tie things together, some guiding principles for the code discussion. It is a bit of a lift, and we're going to go through a lot of different polling to get you there, but we don't need to capture every possible code that a primary care provider might render. The goal is to focus on ensuring the code set includes services that are predominantly provided by primary care. This will help us get through a fairly lengthy list. And just as already been mentioned a couple of times today, we do have a data analysis process in the future. And that'll be really helpful for identifying where there are services that are rendered in those locations by those providers that we might need to circle back and reevaluate based off of their prevalence in the data set. And those will be circled back through the committee in the future. So moving on to the next slide, please. So for today's process, we've broken the large code list into categories. And what we'll do is we're going to walk through each category and vote on them in chunks. The idea is that that'll allow us to take good sized bites at a time and to get through it, but also allow you the opportunity to express your opinion where you'd like. So what we'll do is we'll approach each chunk. We'll Dr. Zerzan-Thule will formally move or ask for a formal movement and discussion, and then we'll move to a poll, and that poll will be whether or not to adopt that specific set of codes into the definition. The standard for it being passed is a simple majority. So an agreement on a code set means a simple majority. And if there's a no, then we'll need to go through an amendment process to get to that simple majority. If there is, it passes, and we'll move on to the next category. All right, if you could go to the next slide, please. So for this process, we will need you to log on to, if you have a web browser handy, you can also use your phone if that's all you have available. You can see that there's a web address. It's poll.cebp/CEBP-OHSU925. So you can also see that on the screen. This is really important, given that this is a public meeting and a formal committee. We do need to track who's voting. When you log in, you'll be asked to enter your name on the landing page. Please do so. That's very important for this process. And then you'll essentially just answer questions as they appear on your screen. And just if you need help with anything, feel free to raise your hand and ask. But some basic troubleshooting, you may need to refresh your page, use a different web browser type, or potentially clear cookies. But again, if you need a hand, just shout. So if you could go to the next slide, please. So this is an example. This is our first set of codes. The first one is preventive medicine services. There's quite a few under this set, so we've broken this into multiple groupings. So let me just briefly walk you through how things are presented here. So you have the category at the top, you have the individual codes in the first column. The second column is a description for that code. The third column, as you may recall from that large spreadsheet that was sent out in the past, you can see how other states have either included or not the specific code in their definition of primary care. As it so happens for this particular set of codes, all of the codes were included in all of the definitions across the different states and the federal programs that are included. The last column is recommendation, and this is largely based on the prevalence of other definitions and HCA initial review. You can see that all of these codes have been recommended to be included. So just to give you a flavor of what this might look like, after I hand this back to Judy to solicit a motion, the motion would essentially be to include the code set as recommended. Pay close attention because you may have one or two codes within a given set that are marked as exclude, and that may influence how you would vote. After the recommendation and discussion, we'll go to the formal polling once again, and we'll see how that pans out. That'll dictate which direction we'll go from there. So, Judy, I will pass it back to you to solicit a motion.
Okie doke. Here I am. So is there a motion to approve this preventative medicine services part 1 code set as final pending future data analysis?
Motion to approve.
Any thanks and any discussion of that? This is the super easy one. It's 100%, but you know, hopefully we'll get some good momentum here. Okay.
Hey, Judy, this is Katina. I wasn't able to get the poll everywhere. Can you put the slide up with the address again? This is
I can put it in the
found.
chat when we move on to the poll as well.
We can't put it in the chat, Beth, because we have the chat disabled.
Oh, never
So
mind. Okay.
maybe let's move backwards. Yes. And it will say that it's waiting for the presentation to begin because we haven't opened the first poll yet.
Got it. Thank you. I must have mistyped.
Okay, let's move to the first poll and try out this new process. Although I'll say that it isn't, I'm still waiting. So maybe I'll try a different place. This is also why we started with an easy one.
Just as an aside, the poll in the materials that were sent out ahead of time is it's CEB POE. Anyway, it was a different one in the materials ahead. It was Public Policy 824.
Sorry about that, Nancy. Yeah, we made an adjustment because we had to make more individual polls. So that's my faux pas. So you're correct in that.
But I think the page that we showed had CB, the center 300 instead of 925.
I voted it and it recorded it in case.
Oh, did it? Oh, good. Okay.
It says recorded.
Maybe there's 2 ways in, fancy technology.
And what is our count on total voting members that are present?
Yes, I was just gonna ask that. Jean Marie, do you know?
In the process of counting.
Okay. Is there anyone that's a committee member that still has not been able to get in?
Yeah, hey, it's Greg. I guess I could try the text approach. I
think we
don't
have
think I
Oh,
can
sorry.
use this.
Oh, okay. You can do the text, that works too.
Yeah, that should work. And I may be off by 1 or 2, but I think we're looking at about 17 committee members present.
That would make sense. Greg is 17.
Yep.
And there we go.
Excellent. Okay, woohoo! We did it, guys. One down. I don't remember how many to go. Maybe 20?
Maybe 20. Yes. All right. Well, then that would pass, of course. So thanks for bearing with that exercise. You're going to want to stay on that page for voting. It'll automatically, or it should automatically update for you as we flip through the slides. So keep things nice and easy. Looks like everyone's able to input. So hopefully we can get a nice rhythm going here. You want to go to the next slide, please? And we'll look at part 2. Exact same concept. You have your codes listed on the left, the description in the second column, the prevalence and other definitions. You can see here, this one is actually not 100%. There are a few codes that were not included in other state definitions. And then, of course, in the recommendation, which is what you'll be voting on whether or not you agree with, is you see that all of these are recommended for inclusion. So, Judy.
Yes. So is there a motion to approve preventative services part 2 as final pending future data analysis?
Motion to approve.
Move approval. Second.
And any discussion of the proposal or the motion? Okay, let's vote. One lingering person, but maybe that's okay since it's 16 out of 17.
Yeah, fair enough. So that would pass as well. Let's move on to the next one. Immunizations, same concept here. I'm going to be talking less and less, absent needing to call something out. But again, keep in mind, you're going to want to likely check out the description, the prevalence, particularly if that's low. And then the recommendation, these are all for include.
And these
So
are
moved.
all giving the immunization. Oh, you want to make the motion to approve immunizations? Any discussion of that?
This is Sharon, and not to slow things down, but I just wondered, like, what did the other places that don't include it have against including immunizations? Like, is there some logic? Do we know?
You know, I don't know. I think, I don't know, we sneakily started this as the ones with the most agreement in terms of prevalence for other definitions. You'll recall that Washington was sort of an outlier in including a lot of codes that other states didn't include. We've tried to sort of show that in a different way and have things that we think are there. You know, I think, does this happen in public health? Does this happen in pharmacies? A lot of immunizations these days, especially in the post-COVID world, a lot of immunizations happen in pharmacies. So, you know, I don't know. Shane, do you have other thoughts about that?
I think you're right. what we aren't looking at while we're looking at these codes is how they defined the location or the type of provider included. So I think Dr. Zerzanthul's thought on that's probably on point. If you do have specific questions, if it's particularly meaningful for you, we can look at which states or entities excluded. So for example, the ones here would be Massachusetts and Milbank's definition. That doesn't tell you why, but maybe gives you a little bit of insight.
I didn't mean to slow down the process.
No,
but
it's
just
okay,
curious.
because it is going to get a little trickier and they all won't go, they all won't go as fast. I will say that I think we're the only state that includes the location. And so we may want to think about that again, depending on what the data shows. So I think that is a piece of it. Yeah. Maddie, you have a question?
Yeah, I mean, I don't have a problem with it. It looks good, but how do we know we're not leaving something out in a category? I mean, I'm not a biller. I don't know, you know? I mean, I mean, has somebody taken a look at that? Like, what if there was a type of an immunization that, you know, we didn't put in here? Is that going to cause an issue or whatever?
I was wondering the same thing.
I think these are the most common. So the codes that we are looking at are codes that have been used in anyone's definition of primary care spend. So we looked at other states, we looked at Milbank, we looked at all the places, the primary care collaborative that have codes. And then we sent it out to you guys. We did get a couple of codes added, but we didn't do an exhaustive search. And I think we don't want to do an exhaustive search because we want to get sort of the main things that we think are primary care.
I'd also just point back to the data analysis. One of the key things that'll pop out if a code is missing that truly is core primary care is that you'll see that you have a lot of utilization that's matching your who and your facility location and your who and your where criteria that is for whatever reason missing from your what definition, and that'll flag it for future discussion. So I agree. I just don't think it's critical if there's anything missing, and what we do have captured should be a breed of primary care.
Don?
Thanks, Judy. I guess the way I'm approaching this is that we want to catch the vast majority, but there will always be changes in codes, additions, subtractions. And so I think perfect might be the enemy of good, and that we try to really get the vast majority, but maybe not worry about every single last code. That's kind of how I'm thinking about it.
I think that's totally right, Sean. That's what we have in the ground rules, which I would point folks back to. So.
Yes. And then Veronica, I think you're a member of the public. So I don't know, Jean Marie.
I think it's kind of important. So if vaccine is state supplied, providers are not billing with these codes. They're billing with the vaccine code and adding the SL modifier to determine that it's the admin charge.
Veronica, so sorry, Veronica, I just want to, I appreciate your question, comment, but I think procedurally this period is really just limited to committee member feedback. So we did do the public comment, and if you want to submit in writing, we'll certainly take your comment now, but just want to reiterate that this is for committee members to give their votes. So, but thanks for your input.
Yeah, and I do think that'll be something that's shown in the analysis. If people don't bill for immunization, then we might not include it, or, you know, maybe we don't include immunizations at all. We'll sort of have to see what different kinds of billing practices there are.
This is Tracy. I think since most pediatric vaccines are state supplied, we want to make sure that we capture that.
Yeah, they should be billing this immunization administration code. I mean, They get paid
Right.
more if they do. So I don't know, but they might not be. So that's why we didn't include individual vaccines on this list, but just the administration of vaccines.
I think, this is Katina, I think the clarification is there is also a 90460 comma SL means it's the state one. So it's the administration of the state supplied one. So adding that, the comma SL in
modifier.
addition, yeah, the modifier. Because I think maybe the 90460 without the comma SL might not capture it, or at least be cognizant to look at if we need the SL or we're able to capture it without the SL.
Yeah, I think we need to make sure that we capture all of that, as that is the bulk of those PEDS vaccines and COVID.
Yeah, so we can go back and look at that. My thought is that the example 90460 would capture everything regardless of whatever modifiers are used, or if there were no modifiers used. So, but Jean Marie, we can go back. Let's make a note to check on that.
Yeah, that's fine.
And then this is backwards. Is there anything else we should chat about before we vote? And I can't remember if anyone made a motion or not. Did anyone make a motion?
I'll move to.
I did.
Vote.
Okay, excellent. So let's go to the next slide.
I believe 9 is our magic number for majority.
Okay, excellent, Sean.
Yeah, we do want to at least give just a second so that we can capture who's voted to support it as well. But it looks like activity stopped. We won't pause too long because we have so much to get through, but we're clearly over the threshold, so that is approved, and we'll move on to the next one. You guys are doing great, so just keep up that energy. We've got a little ways to go. So the next set is special services, procedures, and reports, part 1, because there's a few of them. Same here. What I would note, this is an area where I think only Colorado included the first few. However, it is recommended that these are included based off of HCA review.
Do you have questions? Crystal?
That strikes me as the office emergency care. And that's another one that could potentially add up fairly quickly. And if we're including a lot of those facilities to allow for when they do provide primary care, I just wonder about that code, particularly given the 8%. I don't know if anyone has insights on including that.
We can definitely vote to take it out if you guys don't want it. Yes. Mandy,
Yeah,
do you
I think
respond to that or something different?
well, I think this is going to be a hard one for me to vote on because you've got someone here that are obvious that we would easily include, but then we've got a group that it's like, yeah, I'm having some reservations about it as well.
Part of the strategy, sorry, just to help on the process side, it isn't necessarily that you would include all of the codes when you vote. It is whether or not you would agree with the recommendation for the set. So if you moved to flip something from include to exclude, then when you vote, it would be on that recommendation that includes excluding one of them. So you can definitely accommodate that diversity that you're talking about.
Is there an option to have the recommendation be further consideration, where we can have some more context for some of the ones that are 8%?
Yes. I don't know. Do we want to, I guess it's a question too of whether it's easier to, and if there's agreement to take some of these ones off straight away or do it later. I think I'm open to kind of either. Tony, do you have
Well, yeah, I
comment?
think I just wanted to kind of check my own thought process and make sure that I'm not missing something. I also missed the last meeting. It sounds like our process here is inherently different than in other states. We're going to have a lot of differences because we've already selected out the who and the where. And if we've done that, if you're talking about, you know, a family nurse practitioner in a primary care setting, then we should really include darn near everything that they do as being primary care. If they're doing medical services after hours, for sure, that's primary care. It's better for it to be done there than just refer on to a subspecialty place or an emergency room. I think that's the whole point. So I think that we will be inherently different than other definitions, and we should be more inclusive than others just by the nature of how we've set this up. Is that right? Or am I missing something?
Yeah, I'm sort of on the fence about that, of whether we should be more similar to other states so we can roughly compare ourselves, or whether we should do our own thing. And I think there's pros and cons to both of those. And I think this is sort of where we got hung up a bit at the February meeting. Because yeah, there were different opinions about that. And I don't know, if we want to talk about that, maybe now's a good time to talk about that, because from here on out, it definitely gets messier and the prevalence isn't as much.
But we've already done our own thing, correct? I mean, we've already decided that we've selected out for the provider and the setting, and that's different than other states. Is that right?
That the providers are pretty similar to other states. So adding the setting is different. And I think we're gonna have to see whether that is a strong enough thing to add up to this or not. And so I think we're gonna have to look at the data to decide whether we want to keep the setting there or not. I think it makes it a little more narrow, although I'm not totally sure if it does what I think it does. So we're gonna have to see. Crystal?
Sorry, just one more comment. I agree with your comment that making it as comparable to other states, there's going to be a lot of value, I think, down the road for us, particularly as we look at percentage spent on primary care. And I do think we were pretty liberal with facilities, kind of anticipating that we'd have some of it shake out through these services like emergency, you know, if we have facilities pretty well opened up. And then the last comment I'd make is, again, what we're trying to do is get more, part of this is right to increase our spending to primary care. So just keeping that in mind is the goal, right? So thanks for the time.
Yes, that is the goal. And yeah, I do think there's potential upsides to being closer to other states. Yeah. So I think it depends. This is a good conversation. Tracy?
Yeah, these are good points. I think I agree with Tony that since we have this sort of that first subset, that first call of the set, which is which providers and what setting, that we can be really inclusive on the codes, because whatever they're doing there should qualify. So I would, considering that now, I'd be more inclined to be inclusive of all of these.
Can we step back maybe to the where slide, just to remind people of what's on there? And make everyone dizzy. So these are the facilities. So some of them are a little broader, especially like the multi-specialty clinic or center. And some of them, I think, some of these clinics, especially the primary care clinic that includes the on-site hospital and the multi-specialty, have the potential, you know, like the office visit part, everybody uses the office visit. So that's going to be where like PAs working in, I don't know, a rheumatology, maybe a cardiology clinic would get captured in this because they'd be at a multi-specialty clinic. We wouldn't be able to tell that they're working in cardiology because it's general and it's an office visit, which is everyone. So that's sort of some of an example of some of that issue.
Yeah, that's really helpful. I think I just changed my mind, because now what you're saying is someone could be there for an after hours orthopedic appointment, and it could end up being counted toward the primary care 12%, and we wouldn't be really achieving what we're trying to do.
Yes.
Okay. Thanks for that clarification.
David?
Judy, I'm just processing this myself, trying to figure out which way I would vote. So I have a comment, I guess, and then a question. The comment is, I think I'm thinking along the lines of what Crystal's thinking in terms of being closer to definitions in other states and not being overly expansive so that we don't get a higher percentage and pat ourselves on the back and think that we don't need to work harder to spend more on primary care. And then my question is, if more than half of us vote to reject, but we would all vote to keep the 9920 codes on, how does that work? Like, would we end up eliminating the 9920 set by voting no?
No, and this is, I don't know, Shane, do you want to jump in?
I think the general idea is that you get to a set that you can agree on. So if you end the discussion and you have a vote and the vote is no, then we might take some amendments to the list, which could be including or excluding, and then we'd essentially re-vote.
Okay, that's I think what you were trying to say before. I think I missed that.
Yeah.
Thanks.
One other thing I would point out too, I think that as a committee, your acknowledgement that you're talking about a target that's essentially been established based off of other state precedents and this need for comparability to have a similar definition. That's smart thinking about this. What I think will help actually is that this is a question that you could add to your data analysis, which is for those codes where the prevalence was below, say, 50%, yet you voted to include it, how much is that contributing to your total percent? And then maybe that's something that you look at when you bring the data analysis back to inform the final selection. You can have that be a factor. What is the alignment with other states? And it can be informed by data.
Got it. Thank you.
So procedurally, would one of us move to amend and make a suggestion, or will we just vote? If it's no, come back and discuss an amendment?
If there isn't currently a movement to approve the list as recommended, you could go ahead and propose a change to the recommendation before formally voting on the list in entirety.
So I'd like to propose and open to feedback. Recommend to only include the ones that are at 100% in this set.
Does anyone second that?
I'll second that, Lan.
Can we make the next poll be counting for the ones that are just 100%, and then we can vote on that?
Sounds good to me.
Okay.
So we need to move to approve under that.
Yeah, so Judy, if you can call for a formal motion for the amended group.
Okay. Is there a motion to approve the special services procedures and reports codes that are 100% as final pending future data analysis?
Moved.
Second.
Okay. Good job, guys. I feel good about that conversation. Let's see what happens. Ooh, and we have some disagrees.
Well,
Nice.
You know, it makes me wish in discussion, like we missed ones we should have put in. It's really to hear what people wish was in.
Well, it was moved to approve the set as amended, and then approved. And so I guess what I'd recommend is, you know, as we talked about, there is the second bite at the apple that'll be informed by data. We might need to have a conversation about what we want to see out of the data analysis before it's conducted to help inform some of these questions. Might be a good strategy around that. All right, well, activity stopped. That was approved, and let's keep rolling. There's actually about 17 more, so great warm up. All right.
I think some of these discussions, though, will help us as we get to future ones where it's not all 100%, and then we have to think about it more. So.
All right, we are at Special Services, Procedures, and Reports, Part 2. This one's a little more clear-cut. Prevalence of 100% for all codes. Recommendation is to include.
So moved to include all those.
This is Stacy. I have one comment. Just in the last conversation about the physician's assistants and the ones that are clearly specialty based, so like the orthopods have a lot of physician's assistants, so do other specialties. But now when we went back to that location, it showed multi-specialty. So all of these office visits will get captured by those physician's assistants that work in the specialty offices that are included in the multi-specialty clinics. Am I right in my thought process?
You are correct.
And that is clearly not primary care, right?
Yes. Yeah, and that is why with the OFM report, they decided that 60% of PA visits were primary care.
Okay.
And I don't remember, Mandy, you might remember, did we limit the PAs to general and not the surgical PAs? Or was it just PAs as a group?
Sorry, I realized I'm muted in two places. There were three. So for the PAs, there were three categories of PAs, as I remember.
Yeah.
But I don't remember if surgical was one of them or not.
I don't think so.
Give me a second, I can pull the report up.
It might not be. And so then the 60% was sort of decided.
It was based on the literature. It was actually based on the literature. We didn't pull it. I mean, some other group had actually done research on it, and that's what we went with.
Yes, so there might be tweaks on that that we'll have to sort out.
Well, that sounds like a good follow-up item. It was clearly something that was impactful in the OFM report as well. And was there a motion for the set in front of us as is?
So moved.
What's
Is
the
there-
motion?
Sorry, what was
I-
that, Tracy?
I didn't hear that. What is the motion to approve or what was the
Oh,
motion?
is there a motion to approve special services procedures and reports part 2 as final pending future data analysis? And I think Katina said yes. So moved.
Second.
Okay. Any discussion or comments about that?
I think we're gonna get to 12% faster than we should.
Yes, I do worry the goal is not to get to 12% on the first go round, because I do think primary care needs more resources and investment and attention by everyone. So and other states haven't gotten to 12%. They're pretty similar to, I think, where we are. Actually, we're in the lower. Oregon and Rhode Island have made some nice progress. They've been working on this longer, but I still think they're at like 9 or 10. They're still lower. So
And also, we haven't accounted for non-claims based yet, which would further
That's true.
increase. So
And
we want to keep that in mind. Yeah.
yes, non-claims based has not been included in other definitions. So that is more ground we are breaking, although I think other states are talking about it. So and with the goal of sort of moving to value-based payment and moving some payments to not be on codes, I think that's an important part, but we'll talk about that later. So maybe let's move on to the vote.
And Judy, there are specialty and taxonomy codes that can be used to address some of the issues we're talking about. So I assume that's what will happen in the follow-on data analysis. Is that correct?
So the taxonomy will be used for physicians. That is super well trod, and there's a lot of those. The taxonomy is, I don't know, narrower, but still kind of reasonable for APRNs. I think there's like 10 to 15 different kinds of codes, but for PAs, physician assistants, there really are only 3, no code, medical, and surgical.
Got it.
So that's where some of the messiness comes in.
Okay, thanks.
All right, well, this code set was approved and great discussion. I think the key here is that you're identifying what some of the outstanding questions are that are a little bit independent of voting on the discrete codes, which will allow for both future analysis and consideration in future meetings. So we're going to keep chowing through the codes here. Again, there are a lot. Here, we're moving on to special evaluation and management services. This is where it does get a little bit harder. In that prevalence is maybe less of a guideline for some of these. I do want to flag, we did receive some comments via email about some codes that needed to be added. Some of those were called out were actually included in this subset here. And then the ones that weren't included in the list, we added elsewhere. So I just want to flag those here for those of you that submitted feedback. So here you can see, again, there's more diversity in the prevalence and very important to flag here that the recommendation is we're getting into territory where there are some codes that are flagged for exclusion, specifically the remote monitoring codes here around psychological parameters. So any questions?
And then Judy, do you want to call for a motion? Oh, you're on.
I'm on
Yep.
mute. Yes. Is there a motion to approve special evaluation and management services as final pending future data analysis? No motion?
Judy, do you want to move?
People want to talk about it?
So moved. This is Tony.
Second.
Second.
Okay, any discussion? We've suddenly become very quiet.
This is Crystal. I think it's just a struggle because I'm looking at some of these that I would just say no to. So then you have to discard, vote against the entire list. But I don't know how much time to spend on, each individual kind of disagreement. So I don't know if anybody else is feeling that, but that's maybe part of the silence.
I think we should, you should speak up on the ones that you're wondering about, because this is
That's what I was gonna, yeah, that's what I was gonna encourage too, Tracy.
Yeah, I mean, if we end up taking too long or something, we'll figure it out. But I mean, I think we all want to hear it if you're thinking something shouldn't be included.
Yes. Or excluded.
Right. I know that I'm struggling with wondering between the difference between the remote psychological monitoring. I don't understand the nuance there, but.
Yeah, I'm actually not sure. I think that maybe they all should have been excluded, because why would we not include initial and programming, but we'd include, I don't know, maybe the one that is included is like looking at the data and deciding what you want to change about that. But it is 8%, so you may decide that doesn't hang. And then there's 3 codes about disability exams that we could have a discussion about those 3. And then Nancy, the home or nursing facility visit code is on here. If you want to chat about that.
Judy, this is Ginny, and I'd like to talk about the disability exams, maybe grouping those into 3. I mean, 8%, not very high, but they were all recommended to be included.
Yes, although if you want to exclude them, you totally can. Some of these, as we were looking at again, and Shane can laugh at me because I was like, wait, we said to include those? Maybe I don't agree with that anymore. So, I think some of our taking a stand was just to start this conversation. So I don't have strong feelings about that particular code. You won't hurt my feelings if you say no, exclude that. So Sharon?
Yeah, I'm looking at this, the remote monitoring, physiological parameters, initial and program transmission. I feel like that is definitely primary care, and that's kind of going the way of the future. And just letting you know that at the Alliance, we are working with the Washington State Department of Health on an initiative to actually encourage the use of home blood pressure monitoring with, data transmission to primary care specifically is in the grant to the CDC. It's in there. So I don't know why it's not, but okay.
Tracy?
Yeah, actually, that's a good point too, because we should look at how these things change. So for example, that would free up time in offices which creates more access. So including it, I think is just good because it's part of care that has to happen. If the disability ones, if those are inclusive of like L&I work, I would encourage us to include them because they do take an extensive amount of time, which does limit access. So it is the primary care providers doing that work. And so I think it's important to capture.
Anyone else?
Usually one thing that's hard for me is the percentages and dollars associated with these, you know, so if somebody took these and applied them to a claims data set and came back and said, going with everything that's been recommended, we're at 4%, then I would feel comfortable saying, let's count it all, go with, you know, every recommendation. We don't have to talk about any of these. If we came back and said, we're at 20%, and that's because including all of these codes where the prevalence is low and others, the prevalence of using these in other states is low, that's a different ball game. You know, since we've anchored to some of the other states' percentages as our benchmark. So that's just where I'm struggling.
David, that's a really good point. We're sort of taking just one data point as our reason to include or exclude, which is what other states are doing, and maybe we need more than one data point. I think we actually do need more than one data point, like what it does to the percentages.
Yeah, I'm almost inclined, just looking at the time, if we're going to do a follow-on data analysis, I'd be in favor of just go ahead with all of these, include them all, and report back to us, maybe even by these groupings, what the impact of including some of these codes that have less than 100% or less than 50% consideration.
Sharon?
Sorry, I failed to lower my hand. Whoops, sorry.
Okay. So I think we had a motion. Is that right? I'm losing track today. I'm sorry. I'm not quite right. Shall we move on to voting then?
Sorry, just a
Yeah, go ahead,
question
Shane.
here. I don't think we had a motion for the set. I think what might be interesting is to chase down that last comment. If the group, and it sounds like that there's some agreement around it, or is at least one. I won't put words in your mouth, but there might be, but you could test that theory with a vote. So if you feel strongly that that the single data point on prevalence isn't really sufficient to make a recommendation, and that you're comfortable collectively with setting some sort of standard, like generally in align with the recommendation, and then when the data analysis comes back to do the refinement versus doing the nitty-gritty detail now absent the additional data points, you could potentially pursue that path. I'd check in with Jean Marie and Judy to make sure I'm not completely in left field here.
Judy, what do you think about that?
I think that's reasonable.
So if I'm understanding, Shane, the way that you just said that, wouldn't that be kind of just reversing what we said earlier about not including everything? We do want to try to delineate, so we kind of backtrack and say, actually, let's just err on the side of including everything and then edit out what we don't need later once we look at the data. That's kind of what I'm hearing.
Well, I think the group should discuss the strategy here and then make a motion. You have a couple of options. So you could just run with what the recommendation currently is, knowing that you may not disagree with something on a code level, but recognizing that in the future, when you have the additional data point, that you could refine your assessments and chime in at that point. That essentially allows the data analysis to progress, and then you still get to refine your list. Another option would be to include everything and still go through that process of refinement in the future. Or you may have other ideas on how you want to approach that. I think it's for the committee to kind of discuss and figure out how they want to approach it in terms of strategy.
Yeah, I do think, I don't know, thinking about what David just said, that actually having a smaller code set might be more helpful in the future to target like if, for example, the legislature decided to use this as the place to increase primary care reimbursement. And so they picked what we decided. Then things would be spread out over more places. And so then is it worth it to have some of these very low volume codes, or is it less worth it because you want to focus on sort of what's the main part of primary care? And those are two different approaches that I think we need to sort of decide on in some way. Crystal?
Yeah, I don't mean to add another option, but maybe a nuance is that I'd wager a bet that if we were looking at codes grouped together where, 100%, even 75% of other states are using them, I think we could get through those fairly quickly, leaving us with those others where we may want a little bit more analysis, volumes and costs. So I don't know if we could maybe prioritize those items that certainly wouldn't be represented in other states, so we aren't as comparable. Not sure if that complicates it too much.
It's okay. Tracy?
Shane, I have a question. So does voting to include these enable the data analysis, or is the data analysis already happening on these things? And where I'm going with that is, I feel like I'd like the data on all these things. I don't think we have enough information to select these, especially given what you just gave out as consideration, Judy. If the legislature or anybody's going to do anything with payment on this, I feel like we should have some better ground for choosing these.
I defer to Judy on where they're at in the process for data analysis, but I think this really just gives you a starting place, and then it also drives what additional questions you might ask of that analysis to get to a final decision. Does that sound like an accurate characterization?
Yeah, we actually have very little data analysis resources. So there's zero data analysis happening right now. And, we aren't going to have the ability to sort of go back and go back and go back. And so I think our plan was that once we were through this, we could pull the data once and look at it. And then sort of refine based on that. But I don't think we're going to have the ability to do a ton of data analysis on this. I will also say, for those of you that are with health plans, part of the cost board data call that happens every year will be how we get this data from people. If we're lucky, although I think probably not, we would be able to have a final code set to be included in the July reporting that the carriers are going to do for the cost board, because they're going to pull data then. That's sort of one place that we're pushing against trying to have this code set done. That being said, if we're not ready, we're not ready. I think the lesson from other states is that getting it right when you start and then keeping it the same is really important, because otherwise you don't know if you're really increasing primary care spend. You've got to have sort of a stable place to measure against. And so so that's sort of the other side of that. Being a former researcher, I for sure feel the need for data, and we don't have data right now. I was just looking, I could look up how often, because we have a code set, I could look at how often these are billed in Medicaid, but that wouldn't help because this is supposed to be commercial and Medicare.
only other piece I'd add for committee members, food for thought here, is that we're going to be taking the feedback that we get today and the votes that we get today and funneling that through to one of the other subcommittees of the board, the data committee. They're actually meeting next week and I'm providing them an update. And while I've crafted a presentation that shows them what we were going to talk about, I am also able to pivot somewhat and do a quick turnaround and say, here's what we got to, and here were some of the questions that got brought up. And they're the specific body of folks who would really be able to speak to the challenges of some of these individual codes, maybe in terms of accessibility and relevance. So just putting that out there.
I think we've probably made it as clear as mud. So maybe I do think there's not a single right answer to this. And the conversation about how we get to the decisions, I think, is almost as important as the decisions in figuring out what the right direction for Washington State is. Tony?
Yeah, thanks, Judy. I'm still just kind of processing this. I've got a strong desire for all of us to be on the same page, and I do certainly understand some of the rationale that's been presented to be a little more exclusive, but I still have this tendency to lean towards being more inclusive. When I think about some of the procedures that a good, robust primary care office does, they might not do them very often, whether it's, I don't know, removing a toenail, whatever it is, but those are sometimes the intersection between primary care and specialty. And I don't think that what we want to do over the long run is to disincentivize primary care from doing some of those more complicated procedures, the injections, the excisions, and things like that, because then they'll just relegate back to doing more basic stuff and sending more on to the specialty, which defeats the purpose of what we're trying to do. So if we're doing it under the guise of, well, we'll just make sure we get more reimbursement for the basic stuff, I guess I don't know that I agree with that premise. So maybe I still need a little clarification, but I'm still inclined to lean into being more inclusive on this list, assuming we're more exclusive in terms of who does primary care. If we've got a narrow definition of people really trying to do good primary care, that's why a little heartburn about the subspecialty PA and stuff, but that's not too many. But if we get the who and the where right, then I should think we should be at that point pretty inclusive in terms of what we reimburse them to do.
So could I make a motion? I'm sorry.
Oh, I don't know. I think because people do such varied things with their roles that it is harder, because as an example, I don't think there's necessarily a code if a family physician or an internal medicine physician or a pediatrician works in the ER. Like sometimes people decide to change things or work in the hospital, and they're not a hospitalist, but they're working in the hospital. And so I think we can have the who and the where, because a hospital campus, you can't, I'm not sure that the where can specifically put you in a primary care clinic. That's where this gets a little messy. And so I guess I'm just not sure, but Tracy, you were ready to make a motion?
This proper process, I'd like to make a motion to approve this set with all of the items listed as include.
Okay. Is there a second?
Second.
Okay, let's vote. Okay, I think that's mostly everyone. I know there were 2 people that were leaving early.
All right, so that's approved. All right, when we move on to the next one, I want to lead with a question here. So what you're talking about, there's a few different principles that are being balanced. So this concept of aligning based off of prevalence, this idea that there is at least some incomplete information that makes it difficult to really evaluate right now. And then also this concept of being more inclusive. I just not as a formal vote or anything, I think it might be worth checking in with the group based off of some of the ideas that were put out. In terms of approaching the rest of the code set, you could take a higher level strategy of aligning on prevalence, where the prevalence is 75% or more, or 50% of more, to align with that definition, and that would address the full remainder of the set. We can continue this process as well and go chunk by chunk and collect your input, do the amendments and vote. I just wanted to get a read of the group right now, given the conversation that we just had, where we landed on that. So
I think we're going to continue to struggle with wanting more information. And I wonder if there's a pathway forward with that versus just saying, well, this is our shot at it.
Yeah, so to reiterate, I don't think this is your final shot at it. There will be data analysis that'll show the prevalence of the codes that can help shape a change to the definition if needed. But there are limited resources on that. It sounds like there is some value in having a starting definition to work with, which means we should come up with some process today to get through that. But I don't think you should, I don't know, I guess I do need to ask Judy again here. So let me put a straw model for you guys to attack, which is, so for example, if in the desire to be inclusive, but still align with other states, maybe you set a threshold of, for the remainder of the set, which is a lot of codes, you could consider approving them if they were both recommended by HCA and the prevalence is over a certain threshold, say like 25%. And then that would give a foundational set for analysis to see what the prevalence of the codes are. And from that analysis, you could answer the question of, well, of the codes that have low prevalence that we've included, what is the dollar value? Like how much do they contribute to that 12%? And it would also allow you to answer the question of the things that were excluded, what would their contribution have been? And then you could modify your definition based off of that. So I think there's a path either way, which is either you struggle through the detail now, and that gives you a little bit of a head start that you might want to tweak with data analysis informed decisions in the future, or you can take a broader approach today and then circle back with it'll end up being the same data set, the same set of information, and refine later.
Shane, is there an option, or I guess maybe this is a question for Judy and the group, you know, how with the provider type, I think it was, we had a narrow and a broad. Can we have a narrow and a broad on the procedures where we say if the prevalence and the recommendation are in a certain level, that's the narrow, and then the whole list is the broad?
We definitely can, and I think there's at least one other state that did that.
I'm not sure there was, but Shane, do you remember if there was?
It did narrow and broad. I don't recall honestly.
I thought it was just Washington, but I could be wrong about that, Judy.
Oh, maybe it was just us that did narrow and broad
I think so. Yeah.
procedures. Yes.
But we can be the pioneers on that again, like keep going in that vein. That's certainly an option.
I'm sorry I had to step away for a moment, but one of the things that keeps hanging me up is our definition includes a team, right? And so if any of this stuff is being done outside of a primary care team, or any of the providers are working independently outside of a primary care team, is that primary care?
We wouldn't be able to know.
But given that the team is part of the definition of primary care, shouldn't we somehow try and find out? Because, I mean, it is fundamental to primary care is that it's a team-based approach, isn't it fundamental? I mean, a social working.
It is, but there isn't a way that we know if just Nancy's working on her own in an office or whether Nancy has a nurse and an MA and a pharmacist and whatever else. That's
Judy,
one thing that I don't think any of this measures. And
Yeah.
maybe that's some of what we include in the non-claims based. I don't know if we'll be able to sort out that detail, but with coding, we can't tell that.
Right. That might just be a nuance that we figure out farther down the road and adapt our reporting information for that. It might be more qualitative than quantitative is what I'm thinking there.
Oregon, for example, has a certification for their primary care stuff, and people self-attest.
So we could
So
do something similar.
yeah, there's things along those lines, but I think that wouldn't necessarily be a part of this process.
And maybe a way to think about it too is that if you've defined the who and the where and the what, if you're excluding any of these codes because they might be rendered independently outside of the team setting, you won't capture them for primary care, and that would be problematic. So I think as long as you're answering the question of is this typically provided by primary care? And then there's a secondary set of under what circumstances do we need to think differently about the who or the where? And those can be tackled a little bit separately as Jean Marie was proposing as kind of refining the output.
And I think Tony brought up earlier that if we've defined that the primary care team member is doing something in the primary care setting, then they should just all be included. Right?
Yes, but I don't think we had broad agreement on that. And I think it does run the risk of sort of diluting some different things. So yeah, I don't know that there's a right answer to that, but I do know that there's different approaches to it.
Do we have a motion out here yet, or?
We don't, and actually I was just gonna say, is there a motion to approve the care plan oversight services codes list as final pending future data analysis?
I would like to make that motion.
And is there a second?
It's DC a second.
Okay. Any more comment or discussion about that motion? Let's vote. There's a lot of philosophical conversations we can have on this for sure. Down the rabbit hole.
Yeah, so based off of the fact of this being moved and then people voting on it, it seems like the strategy to get through this really is to go step by step through each of the categories and then identifying where there's questions that need follow-up. That'll allow us to keep moving here. This passes, so this code set and the recommendations would be included. So. All right, let's move on to the next set. All right, consultation. This you can see the relatively high prevalence, all were recommended to include.
Make a motion to include it.
I second that.
All right, thank you. Let's go on to voting. Not seeing any motion that approve or no more voting. Couldn't use motion in that context. This passes as well, so this will be included. If you could go to the next slide, please. All right, same deal here. Home health services, high prevalence, universally all recommended for inclusion.
Oh, not home health, just a home visit.
Oh, home visit, apologies.
Motion to approve.
Yeah.
Again.
Thank you, Judy. Good
Discussion?
catch.
Okay, let's vote. Oh yes, home visit. Nice on the fly editing.
I think that's what we've got left in the group, so that passes. Next group. Complex chronic care coordination services. Prevalence mixed on some, but generally pretty high. Recommendation to include all.
Motion to approve.
Second.
I'll second.
Thank you very much.
Any discussion? Let's vote.
Right, we have it. All right, so that is approved. The next grouping. Non-face-to-face physician and non-physician services. All of these were recommended for inclusion. You can see the prevalence on the screen.
Move to approve.
And the second, Stacy.
Any
there any
discussion? Okay, let's vote.
All right, we have it approved. Next grouping. Nursing facility services. Here, prevalence 25% universally, recommendations to exclude for all.
Does someone want to make a motion to approve, I guess, the
Stacy, I approve.
recommendations on nursing facility services?
I move approval.
Second.
Is there any discussion?
Just to play devil's advocate here, what if you're the primary care doc and you've checked your person into a skilled nursing facility and you can't bill to sort of check them in? Is that what we're saying here?
You can bill to do it. It won't be counted in this spend of primary care. And I think in my experience, a lot of nursing facilities have their own doc. It's become more rare for people to follow their patients in, even though that I think is a nice practice. So I think that that's probably why this isn't included in a lot of other definitions.
I would worry about this if we were voting on including for billing. I mean, our geriatricians do take care of their patients in the facility. So for including in the 12%, I can see that's okay not to put it there, but I do worry that this could end up being the basis for creating billing practice. So
I can definitely say that none of these codes will be excluded from regular business or be used in that way. That's for sure not the intention of excluding things. The intention is really to get at that 12% spend on primary care and what falls into that.
okay, that's helpful.
But it almost feels like it would discourage the primary care doctor from following their person in, and we'd want to not discourage them.
It wouldn't discourage, you'd still get paid. Yeah, things that are rare, maybe I'll try and put it this way. Things that are rare probably, I don't know, in my mind, maybe aren't worth including because it'll be like 0.00000001% of primary care spend. And so it won't really move it in one way versus another. And so again, sort of that focus on what are the main things and what are we trying to do. I think that if we're trying to, or maybe I'll put it this way, I don't think we're trying to capture everything that primary care does in this. We're trying to sort of capture the majority of things, because those things that don't happen very often or around the edges, even though they're primary care, they won't change the primary care spend very much.
But by not including them, Nancy, I think what we're saying too is that just because they're on the fringe doesn't mean they'll suddenly stop, period. They're going to continue to be happening on the fringe. So it's not going to eliminate anything if that's the concern that you're voicing here.
And if, say, in 10 years, we've changed practice and people do follow their patients into nursing facilities more, or I guess the home stuff isn't a good, but you know that primary care is delivered in a different way than it is today, we have the option to change this.
I think that's going to be 5 years top. So we're going to have to come back.
Yes, it probably will be. But yes, that stability, I think, is important to make sure you're moving progress and then reset. So, but this committee will look at what the primary care spend is every year and sort of talk about that and make recommendations. So, yes.
Is there a motion?
Yes, there was a motion. I'm tracking that better. So shall we move to a vote?
All right, that is our full set. So is approved. Those codes would not be included in the definition. Well, let's see. We'll save just a couple minutes at the tail end, but I am optimistic we can get through at least a few more. So let's give it a go. We're the set here all are recommended to be included.
And this is actually one where you might want to say based on the last one, because these are similar to the last set about nursing facilities. You may want to exclude these instead of include them.
Judy, is this referencing assisted living more than nursing homes? Is that the difference?
I am not totally sure.
Or is it like an adult family home? Like, what does it mean? Domiciliary.
It's an important distinction because assisted living is supposed to be mobile enough to go to office visits. And a lot of times we do follow those folks to assisted living, whereas nursing homes are assumed to be in-house, and that those are the facilities that then have their own physicians or providers.
I would agree it makes sense to exclude these if you promise this won't be the basis for payment.
Okay, some systems do send their own physicians into skilled nursing facilities, just to pick another
Yes,
loose
we already
thread.
closed that one though, Sharon. Don't go back.
Okay.
Don't
I was
go
gonna say,
back.
just going back there. Okay, never mind. I'm good.
I am not totally sure if this is assisted living or not. Does anyone who's familiar with codes know?
Since we're not going to get through all these today, can we table this one and have someone research it and vote on it next time?
Sure,
Yes,
that
we
sounds
can.
good.
Yeah, we can commit to that.
All right, well, let's skip the voting and move on to the next. All right, so osteopathic manipulative treatments, low prevalence, but these are recommended for inclusion.
Motion to approve.
There a second?
Okay.
Any discussion?
All right, let's
Okay.
vote.
Yes.
I'm not seeing any additional movements on voting. We definitely have a majority though, so it's approved to include those.
I think that's probably our last one because we have
Yeah.
about 5
Yeah.
minutes left.
Yep.
All right.
We can pick up on this when we come back.
Okay, sounds good. Well, good job, everyone. I know this is really nitty gritty to think about individual services and the combination of setting and provider. So well done getting through what we did.
Yes. So I wanted to tee up a little bit in these last minutes what I want to talk about at our next meeting. We'll definitely go over the code set some more, but one of the things required by the legislation, Senate Bill 5589, includes some discussion about the barriers to the access and use of data needed to calculate primary care spend. How and by whom it should be determined whether desired levels of spending are being achieved, methods to incentivize the achievement of desired levels of primary care spending, and specific practices and methods of reimbursement to achieve and sustain the desired levels of spending. We will send out that legislative language to you to be thinking about, but we have a legislative report that will be due in the early summer. And I thought it would be important, because this is the main document that the legislature will look at and sort of think about our recommendations. I thought it would be important to have your considerations on some of those recommendations be put in this year's report rather than waiting for the next year's report. If there are general statements to be made about primary care or general recommendations to be made about primary care. So we are going to spend some of next meeting talking about what kinds of things we might want to put into that legislative report or make recommendations to do that. So look for that and some thinking. Then in May, we're going to hear presentations about non-claims based spending that will help set up our discussion for non-claims based spend. I think we'll get close to, if not probably through the last few code groupings that we have in our next meeting. So any last questions or thoughts about that? Thank you for your time, because this was a lot.
Well, what's the date on the next meeting?
Oh,
April 27th, Linda.
Oh, yes.
April 27th.
2 o'clock.
Yep.
Yes.
And just a reminder to everybody, and we can send it out as well, but these meetings are always recorded. So I know several of you who missed the previous meeting, and that's, completely, things come up. But it could be helpful to go back and look at those recordings. And we also have detailed summaries of each of the meetings. So I can send those out as a link in email to just as a reminder for folks to access those and make use of them.
Yes. So yes, our next committee meeting is April 27th at 2, and thank you all for attending. I look forward to seeing you then, if not before. Take care. And I'm glad I'm not contagious over the screen because this is yucky cold.